The meeting is live now. You can start the meeting.
Good evening, everyone. I welcome you all to the fifth session of KSOS PG Classroom. Today, we have a case-based discussion on a very important topic in ophthalmology, proptosis, which is very frequently asked as for long case discussion in our exams. And Dr. Anne from Giridhar Eye Institute will be presenting a case on proptosis. And we have an expert faculty here to discuss the case. Dr. Gopal, sir, can you please introduce the faculty?
Yeah, thank you very much, Rehna. So we have with us Dr. Thomas Kuriakos, who is a professor, head of the Department of Ophthalmology at CMC Vellore. He is retired and he has joined our own Cochin, Giridhar Eye Institute. Then we have Dr. Niba Anand, professor and head of oculoplasty at the PGI Rohtak, which is the RIO of Haryana. And then we have our own host faculty, I would say, Dr. Marian Pauli, who is the oculoplasty head at Giridhar Eye Hospital. So this is a case presentation. So we are alternating between case presentation on 1 week and investigations on the other week. So probably the next week we are looking at corneal topography. So over to you, Dr. Ann. You can present the case and be cool and you present the case, okay? Yeah.
Good evening, everyone. Presenting a case of 24-year-old gentleman who is a doctor coming from Ernakulam. His presenting complaint was swelling around the right eye for the past 1 year. Coming to the
your slideshow hasn't started as yet. Kindly see. Just put it on slideshow. Yeah.
Coming to the history of presenting complaints, the patient who was apparently normal until 1 year back gives a history of puffiness around his right eye, which was gradually in onset, non-progressive. There was no history of pain, no history of any diminution of vision. He doesn't have any complaints of redness, discharge, watering, or irritation of eyes. There is no history of double vision, no history of pain on eye movements, no diurnal variation history. There is no history of any increase in size during cough or physical straining or change in position. No history of...
can you just stop and let's go back to the previous slide. Let's take it as one by one. Why are you asking? What is the significance of asking all these points? What it comes to your mind when you say that the patient has a history of painless, what do you call a puffiness around the right eye for the 1 year and gradual and non-progressive? So if you have a patient, I think she's around 23 years of age, 24 years of age. So what all can you think of in such a case if such a history is there? Because see, history taking is very, very important in evaluation of proptosis. Your main thing is history, then the examination, and then the investigations. So when you're taking the history of proptosis, you've taken up so many negative and the positive histories. So there has to be some meaning to it. So I would like you to explain it so that the rest of the people also can understand whoever's attending.
If swelling is associated with pain, it can be due to...
No, see, your patient has only swelling. So let's just concentrate on your patient first. So if you have a patient of this age with puffiness around the right eye, 1 year, as you said, gradual in onset and non-progressive, and there is no pain. So what all can come to your mind just by this one line of history? Can you just make a list of some differential diagnosis which comes to your mind?
It can be a chalazion, which is...
No. Puffiness means there is slight fullness in the lid and also there is periocular swelling, right? So chalazion will not give you that. What else can give you a puffiness at this stage, non-painful?
Blepharochalasis.
No. Blepharochalasis is when you have loosening of skin, the skin folds, right? With inflammation. This is no inflammation, absolutely. What all can come to your mind with this? Okay. Another way is you've asked the history of pain. What is the significance of pain in patients of proptosis?
It can be suggestive of conditions like orbital cellulitis, then any
What else? Relax and tell me. This is just think of this as an interaction. We're not taking any exam. We're not doing anything. It's just that so you can learn by this presentation. So pain would come in all infective and inflammatory conditions, right? So what all conditions can be there? One is orbital cellulitis, we said. Anything else? Now, when you're asking the history of pain, would you go into the details of pain? What type of pain it is associated with any ocular movements, it's a boring pain, what is the intensity, what is the radiation pattern, all these are significant. So can you just explain, suppose the patient has pain in this, any patient has pain, so what all will you ask regarding the pain?
like if there is a worsening of pain with movements of the eye,
So that would signify what?
it can be suggestive of optic neuritis and scleritis.
In a patient of proptosis, let's concentrate on proptosis itself. So what could be the cause of pain on ocular movements in a patient with proptosis?
It can be orbital myositis.
Okay, one, right?
Then
What else?
active stage of thyroiditis.
Eye disease, very good. What else? Can you have pain in pseudotumors?
Yes, ma'am.
What is pseudotumor?
Idiopathic orbital inflammation.
Can have pain in that also. What else can you rule out by pain? Basically, pain is when there is sensitivity of the nerves, right? So these nerves can be sensitized by what? It can be a large tumor which is pressing upon any trigeminal nerve, which is coming from the orbital apex, right? So it will give you a trigeminal neuralgia or pain. So that is one cause of pain again in patients with proptosis. Okay. So what else will you ask about the pain?
Is there any diurnal variation?
Okay, what does it signify?
Usually the symptoms are worse in the morning in conditions like thyroiditis.
I'll tell you. So the points which you're supposed to ask when the patient has pain is one, what is the type of the pain? Is it boring pain? It's a constant pain or it's a dull pain? Then what is the any radiation of the pain going either to the paranasal sinuses, going to the jaw, going to the temporal area, signifying that the patient may have some what you call some sensitivity of the infraorbital nerve or trigeminal nerve, right? And the intensity. So these are the 3 points which you should be asking when the patient has pain. Okay. So if now the third point you've come up as no history of diminution of vision. No complaints of redness, discharge, watering, or irritation. Now, what is the significance of your complaints of redness, discharge, watering, or irritation?
It rules out any infective conditions
Like
orbital cellulitis. Any proptosis secondary to conditions like sinusitis.
Sinusitis will not give you this. What else? The very common thing which we say, which is the most common cause of bilateral and unilateral proptosis in adults.
Thyroiditis.
Thyroid. So whenever you have thyroid, the patient will have complaints of redness, discharge, watering, irritation, foreign body sensation. Very typical of thyroid of thymopathia. Okay. Now, what is the significance of vision?
If there is any compression of optic nerve or if there is any exposure keratopathy, it can lead to blurring of diminution of vision.
Can you have any vascular compromise to the optic nerve by any lesion? One is a direct compression, the other is a vascular compromise. Third is, you've already said exposure keratitis, and there's another cause for diminution of vision is when any large tumor which is pressing upon the back of the eyeball and it is pressing and causing refractive changes or macular folds or macular edema. Again, the patient will have diminution of vision. Okay. Let's go to the next point. No history of double vision. Now, what do you mean by double vision?
If there is any muscle involvement, it can lead to a double vision.
Okay. Now, this muscle involvement can be like in which cases?
In case of orbital myositis,
Okay. What else? There's so many causes of diplopia.
then
Think. Any restrictive changes in the orbit? What are those? So diplopia is basically when the movement is not good, right? So what are the restrictive changes due to? Any fibrosis of the muscles? Where does it occur?
in case of the fibrotic stage of thyroid, inactive thyroid disease.
Okay. Anything else can cause diplopia and proptosis? You can have neuropathies, paralysis of the extraocular muscle due to what? Where are the nerves coming from?
Through the orbital apex.
So, any lesion involving the orbital apex you can think of?
Superior orbital fish.
Heard of an inflammatory condition as Tolosa-Hunt syndrome?
Tolosa-Hunt syndrome.
So what is that?
It is the idiopathic inflammation of the
Orbital apex, right? So it involves all the structures which are entering the orbit. So one of them would be, of course, nerves. So diplopia can be, it seems that I'm teaching instead of asking. Huh? So diplopia can be because of one is the direct infiltration of the muscle due to any disease, especially metastatic tumors. There can be restrictive changes because of the grades of thymoepathy, or there could be paralysis of any of the muscles because of the nerve being involved. Okay. Dr. Gopal, is it okay if I'm going at this speed or should I speeden up?
It's okay, madam. It's okay.
Yeah, you just tell me if I'm going too exhaustive or I'm asking too much. So please tell me so that I can shorten it up. Okay, so the next point you said is history on eye pain of eye movement, as you've already explained. Then is no diurnal variation. Now, what do you mean by diurnal variation? Is there any other thing you should be asking? The next point, right? That is important. No history of increase in the size during cough or physical straining or change in position. So what comes to your mind if the patient has this positive history?
It can be due to orbital varices, any varicocele in the orbit.
Yeah,
then
good.
Carotid cavernous fistula.
Right.
Then recurrent orbital hemorrhage.
So yeah, very good. So what will you do when you have such a patient in examination? You can go to the examination, but maybe I'll miss this. So you ask the patient to do Valsalva maneuver, right? So then you see the increase in the size of the proptosis. If it is there, that means the patient has any of the conditions you have enumerated. Okay. So that means every point which we are taking in the history has a significance. We are not just taking it like it's a list of things which we have to do. Everything has to be ruled out or it should come to a provisional diagnosis. All right. Let's go to the next slide.
There is no history of heat intolerance, diarrhea, or loss of weight.
What does that signify?
It rules out any hyperthyroidism.
Okay, good.
Then no history of cold intolerance or constipation or weight gain.
Hypothyroidism.
Okay. Then no history of any fever, vomiting, or headache.
Now, why do we ask this? In which conditions you have this as positive symptom?
And in conditions like infections.
What type of infections? In proptosis, why do we ask history of fever, vomiting, and headache? It has a significance.
If there is any intracranial involvement,
What?
in patients with
Orbital cellulitis leading to cavernous sinus thrombosis. Right. Next, no history of trauma or swelling in other parts of the body. Okay, that's very generalized. No history of loss of weight or loss of appetite. So this is for basically ruling out malignancies. Right. So you finish off with your history.
Yes, ma'am.
Okay. Now, once you've given me this history, now what things come to your mind just by history? What differential diagnosis can you make for this aged patient? Something should come to your mind when you're teaching the history. So, what all differential diagnosis should come to your mind?
The swelling is over the right upper lid, which is painless and not increasing in size. It can be a dermoid cyst. Then it can be any a tumor arising from the lacrimal gland. Then it can be a dermolipoma.
Dermolipoma, you will see subconjunctival element. Can you see on examination? Chalo, anyway, dermolipoma is not very. Anything else? Lymphomas, any cyst in the orbit, all these conditions, they will give you this type of history. Okay. So next, let's go to the next slide.
Coming to the past history, there is the patient doesn't have any similar history in the past. No history of any head injuries or surgeries in the past. No history of headache, nausea, or vomiting. No history of trauma.
This doesn't come in past history. You should be very, very careful what you are putting in which subcategory, because when you will present this case in exams, this will give you minus marks. Your history of headache, nausea, vomiting does not come in past history at all. History of trauma doesn't come because you've already said it there when you were explaining the present illness, right? So be careful. Okay. Next.
No history of nasal block, frequent respiratory tract infection or epistasis.
Why is it important?
It rules out any sinus infections or nasopharyngeal carcinoma.
Okay. Now, when you go, that reminds me. Once you have a fullness like this, you can you also have a mucocele in the orbit, which gives you this type of history. And if there is a mucocele, what type of mucocele with sinus?
Frontal mucocele.
Frontal mucocele. That also will give you this type of history. Okay. Next, no history of dysphagia.
On your drooping of eyelids. To rule out myasthenia gravis.
Okay.
Then
this again doesn't come in past history. Please be careful when you're presenting in exams. This comes in your history of present illness. All right.
Then no history of systemic conditions like diabetes mellitus, hypertension, or thyroid disease. Coming to personal history, sleep and appetite is normal. Bowel and bladder habits are regular. The patient is non-alcoholic, non-smoker. Coming to family history, there is no family history of thyroid disease, diabetes, or any malignancies. Then drug history, the patient had used moxifloxacin eye drops at the initial consultation for the lid swelling. Coming to general examination, the patient is conscious, oriented to time, place, and position, well built and adequately nourished. No pallor, icterus, cyanosis, clubbing, a significant lymphadenopathy or pedal edema. Pulse rate was 94 per minute, which was regular in rhythm. BP was measured to be 130/80 millimeters of mercury, taken in the right arm, with the patient being in sitting position. Coming to the examination of proptosis.
Just 1 minute. When we are doing the systemic examination, what all, according to the age of this patient, are we trying to rule out? What systemic condition will give rise to proptosis in this age? What is the age of your patient?
24.
23. Okay. Systemically, what the patient may have? Sure. Let's go to the examination.
Patient
We have discussed all those things in the history taking now. So what's the relevance of general examination?
Let's go to the next. Let's go to the next ocular examination.
Examination of proptosis. On inspection, there is an axial proptosis which is unilateral, that is in the right eye, and navsical sign was positive in the right eye. Periorbital fullness was seen. There were no visible pulsations or no dilated blood vessels, no change in size of the swelling during Valsalva or cough. No lag of thalamus was seen. The skin over the swelling was found to be normal. On doing Hertel 6 ophthalmometry, the right eye was measured to be 19 millimeter, and in left eye it was 16 millimeter, with the base reading being 110 millimeters. Vertical dystopia was
1 minute. Why do we take the base reading?
To avoid any inter-observer errors.
One, and another thing very important. When the patient comes to you in the next visit, you would like to know whether the disease is progressing or it is improving. So you put the base level at the same reading which you've done at the previous, and then you measure. Okay, so it's inter-observer and yourself also for serial evaluation of the patient in all visits. Okay.
Then vertical dystopia was seen in the right eye, which measured to be about 2 millimeters. No horizontal dystopia was seen.
Now, how did you measure the vertical dystopia? Is it inferior or superior?
The eyeball was displaced inferiorly, about 2. It was measured with the help of a ruler and a torchlight. Initially, the torchlight was shown, and the corneal light reflex was observed in both eyes. And in the other eye, this ruler was kept in level with the corneal light reflex, and the displacement of the light reflex with respect to the fellow eye was measured in the proptotic eye.
Next.
Yeah, but how did you use that vertical measurement? How did you do the vertical measurement?
With the help of 2 rulers, one ruler.
Okay, use the 2 rulers. Okay. Is there anything else you can use? 2 rulers is one way you can do. Anything else you can use?
Optician's rule.
Yeah, optician's rule with the vertical, this thing you can use that. Yeah. Okay, carry on.
Coming to palpation, orbital margins were found to be palpated to be intact. A well-defined mass of size of about 2 centimeter into 0.5 centimeter was palpated near the lateral orbital rim, extending corresponding to the 9 to 1 o'clock hour positions of cornea with well-defined margins, and the consistency was firm. Mass is mobile over the underlying structures. The skin over the mass was found to be normal, and it was pinchable over the swelling. There was no warmth or no tenderness, no pulsation or thrill was palpated.
Carry on.
The swelling was non-compressible, non-reducible. There was no resistance to retropulsion. It was unable to insinuate the little finger around the orbital rim and eyeball.
How do you, when we are palpating, suppose you want to examine the superior quadrant of the orbit. So where will you ask the patient to look? Straight, down, or up?
The patient is asked to look downwards.
There is a reason for that. Because whenever, suppose you want to examine any quadrant, when you ask the patient to look in the opposite direction, what it does is it tightens the orbital septum. So sometimes you are not able to palpate that mass properly. So whenever we are palpating the mass, the patient has to look in the direction where, in the quadrant where you are examining. Whereas when you're trying to insinuate the finger around the orbital rim, then it should be the opposite direction. Okay. Next.
Then there was no change in size with the jugular vein or carotid artery compression. No infraorbital or supraorbital anesthesia. No lymph nodes were palpated. On auscultation, no bruit was heard. And the Schimmer's test without anesthesia was found to be 18 millimeters in the strip in right eye and 16 millimeters in left eye.
Next.
Coming to ocular examination, head posture of the patient was normal. Ocular position was orthotropic on Hirschberg test. Cover uncover test showed to be orthophoric. No facial asymmetry was observed. Ocular movements in both eyes, they were full in all cardinal positions of the gaze. Coming to visual assessment, in right eye, unaided visual acuity for distance was 6.9 with the near vision being N6, which was improving to 6.6 with pinhole, and his best corrected visual acuity was 6.6 with minus 0.75 spheres with near vision being N6. In left eye, unaided distant vision was 6.36 with near vision being N6, improving to 6.6 parts with pinhole. And the best corrected visual acuity in left eye was 6.6 with minus 1.5 spheres and minus 0.5 cylinder at 150 degree, and the near vision being N6. Color vision in both eyes was 21 by 21 using Ishihara's isochromatic plates. Then coming to anterior segment examination, in right eye, a swelling was present over the upper lid. There was no lag of thalamus, no lid retraction or no lid lag, no lid edema or other signs of the thyroid orbitopathy. Bell's phenomenon was good in right eye. Regurgitation on pressure over lacrimal sac area was found to be negative. Conjunctiva and sclera was normal. Cornea was clear, normal in size and shape, with the normal luster being maintained. Corneal sensations were normal. Anterior chamber was normal in depth, being optically quiet. Iris was normal in color and pattern. Pupil was 3 millimeter round and regular, which was briskly reacting with normal reflexes, and there was no RAPD observed. Lens was found to be clear. IOP with Goldman applanation tonometry was 20 millimeters of mercury in a straight gaze and 22 millimeters of mercury in up gaze.
Okay, so here, 1 minute. Here you have this change. Is it normal when you ask the patient to look up? Is it normal in a normal human being? That little difference of 2 millimeters?
Yes, ma'am. It's normal.
No. So what is abnormal? Increase in IOP, and when?
More than 6 millimeters of mercury is considered to be significant, and it is usually seen in case of thyroiditis.
The reason? What is the reason?
Um, um,
What type of orbitopathy is Graves' disease? Restrictive? What is the pathogenesis of thyroiditis?
in thyroiditis, there is soft tissue inflammation, increased adipose tissue hyperplasia, infiltration of the muscles and fat expansion.
Basically, all these changes, the major changes occur in the muscles. So what happens is, it's a restrictive type of orbitopathy. And the muscles which are most commonly involved in a thyroid ophthalmopathy are which?
In the most affected order, inferior rectus, medial rectus, superior rectus, and lateral rectus.
So now this change of IOP in upcase is related to the muscle, inferior rectus muscle, which is being involved by thyroiditis. So what happens is this muscle, because of the changes, it becomes fibrotic because of the changes of the thyroid ophthalmopathy. So whenever the patient tries to look up, this muscle is tight because it's fibrotic. It is not a normal extensible muscle. So this tight muscle then presses upon the eyeball. And because of this pressure upon the eyeball, this rise of IOP occurs in eyes. Okay? You should know the significance of every test we are doing. All right? Okay, next.
And how do you measure the, when you ask the patient to look up, how do you access the globe, the cornea to measure the intraocular pressure? What do you do?
We can elevate the upper eyelids.
Oh, it may not, they may go up so much that you may not be able to access it, The sclera will present to, cornea itself may not be accessible. So you'll have to ask the patient to go chin down to compensate for that and then look up. Okay.
Yes, sir. Yes, sir.
Do you get what I'm trying to say? Yes or no?
Yes, sir. Yes. Yes, sir.
So you compensate for that eye movement by keeping the chin down. Then you have access to the cornea. Okay, carry on.
Coming to the anterior segment examination of left eye, lid and lacrimal apparatus was normal, and the rhoculus was negative. Conjunctiva and sclera was normal. Cornea was clear with normal.
Let's leave if the left eye is normal. Let's leave it.
Coming to the fundus examination of right eye, media was clear and red glow was present using direct ophthalmoscope. With slit lamp biomicroscopy using 78D lens, disc was normal in size and shape, with the color being pink and the borders being distinct, and the cup disc ratio being 0.3 with healthy neuroretinal rim, and the vessels were seen arising centrally and branching dichotomously with an AV ratio of 2:3. Using indirect ophthalmoscope, macula was normal, foveal reflex was present. Using indirect ophthalmoscopy, peripheries were examined to be within normal limits. Fundus examination of the left eye, media was clear, red glow was present using direct ophthalmoscope. Using slit lamp biomicroscopy with 78D lens, disc was normal in size and shape, with distinct borders, and the cup disc ratio being 0.3 with healthy.
Can't hear you.
Vessels were seen arising normally and branching dichotomously with an AV ratio of 2:3. Macula was normal, foveal reflex was present, and using indirect ophthalmoscopy, periphery was examined to be within normal limits. Examination of thyroid gland, there was no evidence of any thyroid swelling or any other swellings or dilated vessels or pulsations in the neck region. Coming to the central nervous system examination, the patient was conscious oriented. Higher mental functions were within normal limits. Sensory and motor system examination was within normal limits. Right eye, the ophthalmic nerve, normal smell sensation. Optic nerve was found to be normal. Oculomotor nerve was normal with ocular movements being full in all directions. trochlear nerve was normal, and trigeminal nerve sensation over the face and cornea was normal. Abducens nerve was normal. Then facial nerve, wrinkling of skin over the forehead was found to be normal, and taste sensations over anterior two-thirds of the tongue was normal. Eighth cranial nerve, hearing was found to be normal. Ninth and 10th, swallowing was normal. There was no nasal regurgitation or nasal twang. 11th nerve, shrugging of shoulders was found to be normal. 12th nerve, no deviation of tongue to side. In left side, all the cranial nerves were found to be within normal limits. Coming to the system examination of other systems, cardiovascular system, it was all the systems were within normal limits. Coming to the summary.
Okay, 1 minute. There are 2 points you missed. One was retrodisplacement. Whenever there is proptosis, you should be doing retropulsion or retrodisplacement. What is the significance of this test and how do you do it?
Resistance to retropulsion, we place a thumb over the, we ask the patient to look downwards, and with the help of our thumb, we press against the superior, just beneath the superior orbital margin, with the fingers being placed in the temporal fossa, and feel for the feel for the
any resistance to retrodisplacement. Okay, so normally it is not there. Why is it not there in a normal orbit? What is the volume of the orbit?
30 ml.
30 ml. And what is the volume of the eyeball?
15.
How much space does the eyeball occupy in the whole orbit?
1/5.
1/5. And the rest is all made up by tissue, fat, muscles, so many things. So a normal, when you are trying to do retrodisplacement in a normal individual, because the orbit volume is 30, and you have a lot of space in the orbit, which is normally present. Because what are the spaces, orbital spaces?
Periosteal space. Extracornal space, intracornal space, retrobulbar space.
What is is retrobulbar space same as intracornal or not? Don't make up names yourself. What are the 5 spaces, orbital spaces? You should be knowing. Please read. Okay. So as I was explaining, because there's so much space in the orbit, so what happens is in a normal patient or in a normal human being, when we try to retrodisplace the eyeball, it goes very easily and there is no resistance. So if there is resistance, what does it signify?
There is increased orbital volume due to expansion of tissues.
No, but not all cases will give you resistance to retrodisplacement. So what are the conditions where there is an increased resistance to retrodisplacement? What type of lesions?
In case of a thyroiditis,
and solid tumors. You have tumors which can be solid, they can be cystic, they can be spongy. You have various types. So all solid tumors, they will have an increase, they will cause an increased resistance to retrodisplacement. But if the tumor or any cyst is present in the orbit, again, there will not be a resistance to the retrodisplacement because the cyst is compressible. Okay. Another thing you had talked about color vision. So what was the significance of color vision in this patient?
If the mass is extending posteriorly and compressing the optic nerve, it can lead to impaired color vision.
So the color vision evaluation or color vision testing is important in which type of conditions if the optic nerve is being compressed? in very early stages of optic nerve involvement or optic nerve compression, because there the patient may not have decreased vision. Patient may have a bilateral involvement of the optic nerve where you cannot elicit RAPDs. So there are, or they can be very early lesions where you cannot have any changes in the visual fields. So there are 4 criteria for seeing the optic nerve involvement of compression. One is vision, the other is RAPD, third is visual fields, and fourth is color vision. So when the first 3 conditions are present or very early lesions, then only your color vision would be significant. All right. Okay. Another thing, what are the various types of exophthalmometers which are available?
Hertel's exophthalmometer, Leud's exophthalmometer, Naugil's exophthalmometer.
Now, what is the difference or the advantage of one over the other? Hertel's is, what is the advantage of Hertel's?
In Hertel's exophthalmometer, we
Batao, Shamash, you know it. Just can't take it out. What do you do with Hertel's? It's a binocular measurement at one time, right? Right?
both things can be seen at the same
At
time.
the same time. And where do we place the Hertel's exophthalmometer? That base level. So where do we place the Hertel's exophthalmometer?
Over the lateral orbital ring.
Okay. So in conditions where the lateral orbital rim is not there, either because of maybe a lateral orbitotmy has been done previously, or there's a history of trauma or fracture. So in those conditions, which type of exophthalmometer should be used?
Naugil's exophthalmometer.
Very good.
Can be placed over the superior and inferior orbital margins.
Is there any way of measuring proptosis other than your exophthalmometers?
Help of a plastic ruler, simple ruler, we can.
So how do we do that? Because many a times you may not be having exophthalmometers, or they may be out of function. So you have to measure. You have to confirm your diagnosis. So how do you do it with a simple plastic ruler?
It can be placed. It can be placed parallel to the parallel to the ground, and we can measure the
where is it placed? Parallel where? Where is it placed?
Near the lateral orbital rim. It is placed, and we can measure the outermost point of the cornea, the reading where the cornea touches.
Would be your normal. Okay, so if it is more than 21 or a difference of more than, all right. Now, what are the precautions or the instructions you give to the patient when we are doing exophthalmometry?
The patient is asked to look straight.
And something which you also do, what is it? You sit at the same level as the patient to remove any parallax. So whenever you're doing exophthalmometry, you're doing any measurement, these 2 things have to be seen that they are there, then only you do your measurement. Now, any other way you can measure proptosis?
We can measure the proptosis radiologically.
How?
In safety, we measure the endozygomatic line, and
now which first is which what is the level of that film, and which type of CT film it has to be?
Axial film.
And mid-level. Okay, so how do you decide the mid-level? When you are as an ophthalmologist, you have been provided with the CT films. And how do you, when you have to measure the proptosis, so you have to know what is a mid-level axial CT scan, right? So what is a mid-level CT scan? Axial scans are taken from how?
Madam,
is it?
Madam, may I just interrupt you?
Yeah.
Can you ask questions to the other people in here also? Can some of the postgraduates, turn their video on? Anju, Sara George, Akanksha Yadav, Neeru Yadav, Aparna, Chetan.
Yeah, I can ask these. A few of them are
Yeah.
my own PGs.
Yeah.
So
Can you please on your videos so that you please involve yourself?
Yeah, I think that's
Otherwise,
the idea. We should not put all the stress on the presenter, right?
Yeah. Yeah.
See, my main aim is that whoever's listening and whoever's presenting, they should know that these questions are important and they can be asked when given a long case of proptosis. It's not. I'm not putting a stress on the this. I'm explaining and giving answers myself so that they learn also by this class.
Sure, ma'am. Yeah.
Yeah.
Can you ask your PGs to please,
Okay, so who's there? Dr. Neeru is there? Who else is there?
Yes,
Okay. Okay, Dr. Neeru,
can we have an active classroom? Yeah, with
Yeah.
all of you bristling with energy.
So have you been listening to the presentation, Dr. Neeru?
Yes, ma'am. Yes, ma'am.
So Dr. Neeru is a final year exam going PG of our department in PGMS Hotel. So we were discussing that what are the various ways of measuring proptosis. One, Dr. Annie has said that it is the exophthalmometers, the different types of exophthalmometers. What is the other way of measuring the proptosis? She was talking about CT scan. Okay. So what is that way by which we can measure the proptosis on a CT scan?
Ma'am, CT scan, the axial film, we get a scout film that shows
Now
the
you have
level
to,
at which.
okay, now you have to explain what is the scout film.
Scout film is the film which is provided with the CT scan, one film which shows at cuts at the various levels, so that so we know from where at what level the axial scan has been done, and the one which starts from the apex of the orbit, in that scan we can do the measurement.
That is not mid-level. What is mid-level of orbit?
Apex, the one which was having the from the apex, the maximum diameter.
No. In axial scans, that the mid-level is that when it is at the near the equator of the eyeball. All right. So that is a mid-level axial scan. So how do we measure the proptosis on that? Dr. Neeru, how do we measure the proptosis on that mid-level axial scan?
Ma'am, scales measure. No, I don't know.
Anybody else who can contribute to this question? Any other people who have logged in? Any PG, please?
Madam, I think you'll have to ask names. Any PG, no PG.
So the problem is I'm not able to see all the PGs who are logged in. That's the thing.
Okay.
So, yeah, so that's
Okay,
why I'm
Anju, can you come in? Anju? Yeah.
Joined 2 weeks back.
Oh, okay,
She
okay.
won't
She's
be,
baby. Okay.
Christy, can you answer the question? How will you measure radiologically?
Anybody who can answer this?
In CT, we can measure the distance from the corneal apex to the line drawn between the lateral orbital rims.
So what is that line known as? Interzygomatic line. Okay. IZL. Okay, so the normal value should be how much?
The normal value, it is about 9.
Up to 21, as we take it in eyeball. So up to 21. So you have that scale on the CT. Do you know how to read a CT scan film of the orbit? We have a scale which is given on one of the films. So it's like a, what do you call, a comparative scale. So where they give you that this much of millimeter on a CT will give you this much in real life. So when you convert that, anything which is up to 21 is normal, anything beyond 21 is abnormal, means that the patient has proptosis. Now, what is the name of this method we are using?
Milan and Proctor method.
Hillel and Proctor method, right? Very good. Now, what is the other way? One is this Hillel and Proctor methods. Another thing which you can do on CT itself. Do you know that method?
From the interzygomatic line to the posterior sclera
margin.
Posterior sclera margin.
Okay, very good. So what happens if there is proptosis in this method?
If there is a proptosis, this measurement decreases. That is, normally it is about 9.6 mm. So if there is proptosis, it will be less than 9 millimeters.
Very good, because the eye protrudes further. Very nice. Okay. Anybody wants to ask any question? Most welcome, the other two examiners.
So how do you palpate? When you palpate, which finger do you use actually to palpate? Or do you use many fingers, one finger?
To insinuate between the for doing insinuation, we use little finger.
Okay.
Then for assessing the resistance to retropulsion, we use the thumb.
Okay. Yeah. So insinuation you do with the little finger and make sure you don't have nails and things like that poking into the patient. Yeah. Okay. Sure.
Okay, now you have Dr. Ann, you were presenting. Any other questions, or any questions rather from the audience or from the logged in PGs you want to ask regarding the whole case up till now? Okay, so now you have done the examination, right? So you have all the findings, you have the examination, you have the history. Now you have to give me a list of differential diagnosis according, which is very specific to your patient. Can you do that for me?
One is dermoid cyst.
See, first we will talk about more common causes, right? So dermoid cysts are common. I mean, can you classify dermoid cysts? Anybody who is logged in can answer the questions, please. What is the classification of dermoid cysts? Orbital dermoid cysts. You can classify them as superficial or deep. Now, anything which is anterior to the orbital septum or the orbital rim is superficial, and the deep ones are posterior. So normally the most common type of dermoid cysts are superficial, where you can see it at the angles. Why are the dermoid cysts mainly seen at the medial and the lateral angle of the orbit? Dr. Ann, you're presenting the case. You know the reason why dermoid cysts are mainly present at the angles of the orbit? What are dermoid cysts? Can you just tell me?
Dermoid cysts have
Dr. Neeru, if you are still logged in, can you answer this question? What is a dermoid cyst? So I'll answer it for you. Dermoid cyst is basically a cyst which is formed because of the pinching of the ectoderm while the suture lines are fusing during the embryonic stage of the fetus. So what happens is the ectoderm, or normally which covers the skin or is an outside layer, it gets pinched and gets converted into a cyst within the tissue. So that is why these dermoid cysts are more common at the sutures of the orbit. We have two sutures. Lateral we have the frontoethmoidal suture, frontozygomatic suture, and the medial side we have the frontoethmoidal sutures, and that is the reason why these dermoid cysts, when we see, are more commonly present in the ankles where the sutures are present, which are already fused in a normal human. All right. Now, another way of classifying the orbital dermoid is exophytic or endophytic. Now, what is an exophytic dermoid cyst? I think the diagnosis of your case is orbital dermoid, right? Dr. Ann, yeah. So you should be telling me what is the classification of dermoid. So your first differential diagnosis was an uncommon cause of this condition, the presentation of this patient, because the orbital dermoids are uncommon. Mainly we see them on the outside, when you can see them as a soft fluctuant swelling at the angles of the orbit. So can you tell me of more common causes of this type of a presentation in a patient of 24 years of age? See, our main aim, as I said earlier, is when we are taking the history and the examination, we have to make a battery of differential diagnosis. We all cannot depend only on investigation. See, investigations definitely help us. But as a clinician, as an ophthalmologist, you should be knowing what you are actually looking for. Something has to come to your mind when you are ordering the investigations and planning the management. So tell me more common causes of this presentation. One is dermoid cyst, okay.
Lacrimal gland tumor.
At this stage, what type of lacrimal gland tumor will be present? Pleomorphic. Very good. Anything else? There is fullness in the upper eyelid, right? So what else? Neurofibroma. So only orbital component can be present. It slowly grows. Anything else? Now, if you have if you're suspecting a neurofibroma, so what all should you be doing extra in this patient as examined?
We have to do a detailed systemic examination.
So what will you find on your systemic examination in a neurofibromatosis patient?
There can be capillary spots. Then
anything in the eye?
Iris lymph nodules in iris.
So that is why I'm saying it is important to make a battery of differential diagnosis, so that you can retrospectively then go back to the patient and look out for these particular signs and signs which the patient may be having, which you may have missed out in the first examination. Okay, any other differential diagnosis can come to your mind at this age, this type of presentation? Come on, you have to think. Mucocele, frontal mucocele. Okay, anything else? What are the lesions which are the most common lesions which are present in the superior orbit? It is definitely superior orbit because there is this downward displacement of the eyeball, so it has to be in the superior orbit only. That is why the dystopia is inferior. So what are the lesions which are more common in this, except for these three which you've already enumerated?
Any meningoceles.
So now when you are suspecting meningocele, what is not there in this patient? What happens when a patient is of meningocele or meningoencephalocele? What extra examination will the ocular examination will have?
There can be the proptosis may be intermittent, like more associated with post.
Patient will have pulsation, all right, transmitted from the intracranial. So you will have bruit, you will have thread. Okay. All right. Anything else? Just let's us be a little quick. It can be lymphomas, they can be schwannomas, all these conditions which are present more commonly with this type of history, slowly progressive, non-progressive, non-painful, upper orbits. So all these things should be kept in your mind and the examination should be done. All right. Chalo. Now let's skip your slides. What is the next slide? Summarize.
24-year-old male who presented with a complaint of swelling around the right eye for past 1 year. On examination, his best corrected visual acuity in both eyes was 6.6 and 6. And there is a right proptosis with the Hertel's measurement right eye 19 and left eye 16 with the base reading 110 millimeters. And there was a vertical dystopia of 2 millimeters in the right eye, and a well-defined mass was noted near the lateral orbital rim in the upper lid, which was firm in consistency, and the mass being mobile, and the margins were regular. The skin over the swelling was normal. Both anterior segment and fundus examination of both eyes were within normal limits. Coming to the diagnosis, right eye unilateral axial proptosis.
Why have you named it as axial? What is axial proptosis? What is axial proptosis and what is abaxial proptosis?
Axial proptosis, it occurs along the axis, causing protrusion of the eyeball.
So it's a straightforward protrusion of the eyeball, but here your patient has inferior dystopia. You yourself have told me there's a vertical dystopia of 2 millimeters. So does it become axial or abaxial?
Abaxial.
So abaxial or eccentric proptosis. This is not axial proptosis. We are all concentrating on your findings. So it is a unilateral, eccentric, or an abaxial proptosis with inferior dystopia. All right. Sure. Now, another thing which you have missed is when there is a mass in the upper eyelid and you are trying to say that it may be a lacrimal gland tumor. So what another examination you should have done is that you should have lifted the upper eyelid, just retracted a bit, and asked the patient to look in the opposite direction. That means the patient will look down and in and try to see the lacrimal gland. Now, what are the main parts of lacrimal gland?
Orbital part and palpebral part.
So which part is seen by this examination?
Palpebral.
The palpebral. So if you are trying to rule out, or if you're trying to see that the patient may be having, because according to the examination, definitely is in the supratemporal region. So you should look out for the lacrimal fossa. Okay. So next. Thank you. Tell me your CT findings.
This is axial CT section showing.
Which one is axial?
First one is axial and the second one is coronal section. The axial CT showing hypoechoic mass near the lateral orbital rim of the right eye, which is not eroding the bones, and it is a well-defined localized mass.
Have you got a contrast enhanced CT for this patient?
No.
Okay. All right. So what is your probable diagnosis?
Can be a
because time and again you are concentrating on orbital dermal, right? Now, considering this position, what is your probable diagnosis? A lacrimal gland tumor. All right. Now, can you tell me, enumerate me the differences on CT scan findings on an orbital tumor, and the lacrimal gland tumor? The other diagnosis is dermoid cyst, third diagnosis lymphoma. So these are the main three conditions we should be concentrating upon. Of course, definitely we can have surprises on excision biopsy. So what are the differences in the CT scan? Anybody who logged in, any other PG can help her or answer me. What are the different findings, CT findings in all these three conditions? Then only you will be able to differentiate. Everything is not dependent upon just fixation by itself. Can you, what do you call, explain your coronal cuts?
In the coronal section of CT, showing well-defined hypoechoic mass seen in the right eye, in the just beneath the lateral orbital ring, and it is which is more anterior, not extending posteriorly, and
Okay, so when we are explaining the CT scan films and we say that an image is isotense, hypotense, hypotense, what is the reference we take as the intensity?
the vitricium.
Normal. The extraocular muscles. Okay, so the reference level is your extraocular muscles. So according to the extraocular muscles, then we say whether the lesion is hypointense, isointense, or hypo. All right. Have you got an MRI done for this patient? Now, in such a patient, can you tell me the advantage of a CT over an MRI, or vice versa?
We can look for any bone erosion.
So this bone erosion, which is not present in your case, can be present in which type of conditions? It can be present, bone scalping can be present in both the pleomorphic adenomas as well as orbital dermoids because they're well encapsulated benign tumors. So when they press upon a particular part of the orbit, they can cause bone scalping if they're present for a longer time. But if there's a bony erosion, which is irregular or a massive erosion, then the diagnosis would be more towards a carcinomatous or a malignant lesion. So even if the scalping is not there, but still your main diagnosis should be an orbital dermoid, deep orbital dermoid, or a lymphoma or a refractory. All right. Now, what is the advantage of CT over MRI in orbital lesions? Generalized.
We can look for the involvement of bone. Then we can assess any invasion into the sinuses.
That you can see in MRI also. What is the disadvantage of CT? Can you tell me? What is the disadvantage of CT over MRI?
So
do we have any exposure to X-rays during CT? What is the principle of CT scan? Basically X-rays which we are projecting to the orbit, right, and taking thin slices. So it's a multiplanar thin slice topography of the orbit where we are using X-rays. So the disadvantage of CT over MRI is that there is an unnecessary exposure of the X-rays to the patient. So definitely X-rays are harmful to the body and to everything. And second is that it is better when you want to demarcate the bony lesions, the CT scans are preferred, whereas MRIs are mainly for the soft tissues. All right. And MRI, the only disadvantage of MRI is that it takes a longer time. So if you have a patient which is post-traumatic, disoriented, uncooperative patients, small children, so in those conditions, we would prefer to do a CT as compared to an MRI so that we don't take a longer time in doing the scans. Okay. So now suppose you have come to the diagnosis. I've given you the diagnosis, two diagnoses, orbital dermoid and the crimal gland. How would you go ahead with the management of this case?
After doing investigations, we can.
What are they? You've done the investigations, you've done the CT, MRI, you've done the general tests. So how do you proceed with the patient? Should we wait? Should we operate?
We should operate to assess we should operate and send for the biopsy and plan. Then depending upon the depending upon the histopathology, we need to plan further management.
Okay, now
Clinically, you want to do. Sorry.
No, you go ahead. Please go ahead. I've asked enough questions. Please go ahead.
No. No, clinically, if you're suspecting dermoid, you will still do a biopsy, is it? Would you plan a biopsy?
1 minute, if I can interfere. What are the different types of biopsies done? You should know that.
Incisional biopsy, excisional biopsy.
So in this, which type of biopsy are you talking about? I think that's what Dr. Saab is trying to ask.
Excisional biopsy.
Okay, fair enough. Sure. Okay.
Now, what is a precaution taken while excising or doing an excisional biopsy of a dermoid?
Not like
you have to take care that it doesn't rupture, because if it ruptures, it causes intense inflammation in the area of the surgery. Okay, so if it ruptures, then you have to thoroughly, copiously irrigate with normal saline. Some people even use corticosteroid, mild solution of corticosteroids for irrigation. All right. So all cystic lesions, if they are easily accessible in the interior part of the orbit, should be excised in total. No wall should be left for any encapsulated lesion, even if you were suspecting that it could be a pleomorphic adenoma also. So the whole wall has to be removed. The reason for this is one, in dermoid, because it stops the inflammation, and the other is that if any cyst wall is left behind, there are high chances of recurrence in all patients. All right. Fair enough. Which year resident are you, if I can ask?
second year.
Okay, then it's okay, I think. But you need to study a little better, more for your exams. You have another year to go, definitely. But it was a good enough presentation. You knew many things, but there were a few things which I think you'll learn when you go to a final year residence. Okay, I'm done with the questioning. Anything else?
Dr. Thomas, would you like to add something?
What approach would you do for external biopsy for this patient? And are you
Question
there?
should be open to all, sir.
Oh yeah, anybody.
The
Okay.
problem is people are not interacting.
I think there must be exam going PGs. She's a second year. Come on.
Don't put the stress on her only, please. She has been brave enough to present the case in this online forum. The others should help her.
And you can answer then, I think.
Dr. Thomas, would you like to answer for her? You asked the question, you can answer.
So yeah, you would Yeah, so like in this particular case, you could just go a transconjunctival and exercise. I presume that's what was done. You don't really even have to go outside the, you can just go transconjunctivally and remove it. It is possible. And that would be probably, in terms of cosmosis, everything, that would be the best way to probably do it.
The biopsy has been done for the patient, Dr. Ann?
Yes, ma'am.
Okay, so can you tell me what are the findings, histopath findings in orbital dermoid? So your diagnosis ultimately was orbital dermoid or a lacrimal gland tumor?
You are.
Report is,
On histopathology, what was findings?
report is awaiting, ma'am.
Achha, report is awaited. Okay, so can you just tell me what are the histopath changes in orbital dermoid?
Uh,
What all will you find within the cyst?
it can contain ectodermal components like hair, tooth, and pultaceous material. Then
Sebaceous material, which is very common in dermoids. So mainly all ectodermal origin things are present because the ectoderm is actually going inside and forming the internal lining of the cyst. So all ectodermal origin structures will be present within your cyst. All right. And in lacrimal gland, because most probably if it's a lacrimal gland, it will be a pleomorphic adenoma because it's a very small size, non-painful, slowly progressive. So all things are going towards pleomorphic. So do you know what are the histopath changes of pleomorphic adenoma? You can go ahead. Any other questions anybody wants to ask? Any PG who's logged in, please ask. This is a good platform to learn and ask.
Just before this, I mean, it was just a clarification. With this sort of CT picture, pleomorphic adenoma, wouldn't it be more isodense?
Definitely it'll be
rather
more
than-
isodense, but still because
looks more
considering the history, considering the examination, and because it's present in the lacrimal fossa, so I think that can be kept as a differential diagnosis. But lymphoma will be rolled out now on a CT cell. I was talking about the DDs when the patient, when she did not tell me the CT cells.
Okay. Okay.
Because there are different types of pleoma, I mean, like the benign tumors, it could be even one of the other benign tumors of the lacrimal gland, where you can have a very varied
Yeah, sure.
intensity of the lesion. It could be hypo, it could be hypo, it could be even variable. So, but I think probable diagnosis should be one of these two. And then you let me know what is the problem when the histopath comes, what it is.
Marian, do you have anything to add? You are the person who has managed this case. So what is the biopsy report and how did you manage the patient further?
Actually, we went ahead with the lid crease approach because it is attached to the periosteum, and if you look very carefully, he has got a small dumbbell component also. So there was a track here. So external lid crease approach, cyst rupture during dissection because he had chronic inflammation also in between. Then we removed the whole thing. Histopath is awaited now, and he is doing fine. His glow position has turned normal. That's it. No complications also. Thank you.
Yeah, I think that is actually, I did not want to interrupt, but I think definitely a superior or the lid crease incisions are very cosmetic. So that they are the preferred incisions given for, unless and until, of course, the lesion is more interior, like Dr. Thomas said. But here, because when we, I don't know whether you must have lifted the upper lid. If the lesion is not seen so interiorly, the preference would be to go through the skin, but definitely through a lid crease incision. So that gives cosmesis to the patient.
Yep. Thomas sir, anything to add?
Yeah. No. I have no other questions there. No.
And what complications can you expect in this case during surgery? One is rupture of the cyst. Second, any other injury to the other structures? Because our differential was lacrimal gland pleomorphic adenoma, one of those differential, no? So you can see the lacrimal gland is sitting just near to it. So yeah, so take care of the lacrimal gland during dissection, during surgery.
Dr. Anne, another thing, can you just tell me, I think you've not read the classification yet, but there are two types of, like, you can classify the dermoid the orbital dermoids, even whether it is sutural or juxtasutural. So the juxtasutures are the ones which are not in the lining or a part of the cyst wall is not involved or incorporated within the suture line. So the juxtasutures are the ones which are easy to remove, and generally we do not leave any we do not find that there is any left behind ectodermal lining within the suture line. But if the patient has a sutural dermoid, like these things you can see only per op. So if that is there, then after you remove the cyst, extra care should be taken to see to it that whatever ectoderm lining or whatever cyst lining you can see, which is incorporated within the suture line, should also be removed, so that to prevent recurrence. All right.
Yeah, if that's almost finishing our class today, Rehna.
That was a very excellent discussion on proptosis, starting from history, going through the positive history, negative history, and differential diagnosis, and why each history has been told by Anne, everything, and even the examination part, different techniques, investigations, and management. Thanks a lot, Neepa ma'am, Thomas sir.
Thank you to you people, to the Kerala Society, Ophthalmology Society, for inviting me. I really enjoyed taking the class. I hope it was not too exhaustive for the PG.
No, ma'am, it
Thank
was
you so much.
good. I'm sure that the PGs would be
The advantage is that this will remain in YouTube and they can hear
Yeah.
it any number of times.
It was a pleasure actually to join you people on this platform. Thank you so
very
much.
Thank you, Thomas sir. Thank you, Thomas sir, very much. And thank you, Marian and Anne. And
Thank you very
I am
much.
not thanking a lot of other PGs who did not show their face at all.
You should go and scold them.
Thank you. Good night.
Okay,
Good night. Thank you
sir.
so much. Thank you.
Thank you, sir.